Okay, good afternoon, everybody. Thank you for coming to today's webinar. So today we are going to talk about treatments for adult ALL, and I hope you will find it useful. So just to introduce myself, I'm Charlotte. I'm the Patient Advocacy Manager here at Leukemia Care, and I will be chairing today's session. I'm joined by a number of panelists who I will get to introduce themselves in just a sec. Before we start, I just wanted to let you know how you can send your questions into the webinar today. So if you're attending on Zoom, we won't be allowing anybody to ask questions by raising their hand or unmuting themselves. If you could instead use the chat function, full instructions have just been posted in the chat box, so I hope that's useful for everyone. If you're watching on Facebook, we can take questions via the comments, so just post a comment under the video, and we have a colleague monitoring the video and sharing the comments with me so I can pick up those questions if possible. Please do ask questions, as we want today to cover everything you are interested in and not just what we want to tell you. So I hope you all find it useful from that perspective. So start with introductions then. Maybe Claire, could you just say who you are and where you've come from today?
Yeah, absolutely. So my name is Dr. Claire Roundtree. I'm a consultant haematologist in Cardiff, and I'm also chair of the adult NCRI subgroup.
Great, thank you, Claire. We're also joined by Catherine.
Hi, hello, I'm Catherine Griffiths. I'm a acute lymphoblastic leukemia nurse specialist. I'm based in Nottingham City Hospital. So
great, thank you, Catherine. And Tino, are you there? I'm wondering whether Tino's now having technical issues. We'll perhaps come back to Tino after Claire's presentation. So Tino is going to speak from the ALL patient perspective today, which I'm sure you'll all find useful. So today's session is going to start with a fairly short presentation from Claire, giving her thoughts on an overview of the treatment landscape for adult ALL at the moment. And I hope you all find that a really useful introduction. And then any questions, as I said at the beginning, please do post them. We're keen for you guys to get what you need from today's discussion. So Claire, may I hand over to you?
Yeah, absolutely. So just... Can you just confirm you can see those slides?
We can, yes.
Yeah, great, fantastic. Lovely. So what I wanted to do today is to just talk a bit about adult ALL, about where we are currently and perhaps what's coming. So this is the overview of what I want to talk about. I want to just explain briefly how ALL is diagnosed and really how we risk stratify patients. So I want to talk a little bit about the importance of cytogenetics of leukemia. I want to talk about patient age and the relevance on how treatment is delivered and potential outcomes. And I want to try and explain minimal residual disease. It's something we talk about a lot in the management of ALL, and it's something that often people find difficult to understand. And then I'm going to talk really briefly about treatment, not with any real detail, just about what the aim of treatment is, and then spend a little bit of time at the end just talking about new drugs and potential ways forward for the future. So what is ALL? Well, it's an aggressive cancer of white cells that are known as lymphocytes. And there are two main groups of lymphocytes that we all have, B cells and T cells. And ALL is an acute aggressive cancer of either T cells or B cells, and it usually presents as an emergency. And most patients will present with signs or symptoms of the fact that their bone marrow is no longer working properly. So that might be bleeding, it might be recurrent infection, it may just be real tiredness and a sense of the symptoms that you get with anemia. And one of the things that almost always is obvious to people in the laboratory when somebody has a blood test is that you can see the leukemia cells in the blood on what we call a blood film, which is when we make a smear of the blood. Who gets ALL? Well, you'll probably all be aware that ALL is primarily a disease of children. And so this is just data showing you really the incidence of acute leukemia, acute lymphoblastic leukemia by age. And so you can see that the average age for getting leukemia is the age of 6. So it's primarily children that get this disease. It gets less common through late teenage and into early 20s, and it's really extremely rare for people in their 30s and early 40s. But what you can see is that the incidence then starts to go up with the older age range, so that actually patients over the age of 70, the incidence is about the same as it is in older teenagers. So how do we actually diagnose ALL? Well, in the first place, we can see leukemia cells down the microscope, and we can see that in blood and we can see that in bone marrow. But when you look by eye, you can't tell what type of acute leukemia it is. You can just tell that there are very aggressive looking cancer cells sitting there. So there are then specific things that we have to do. And what most laboratories will do in the first place is something called flow cytometry. And this is where we look for the markers on the cells to try and understand which group of cells have become cancerous. And so the markers that we look for they're all have a number, so they're called CD something. And the reason that I'm explaining this is because it's really important for some of the treatments that we've now got available to us. But essentially, these are all markers that you normally see on the surface of blood cells. But quite often what happens is that they will be in abnormal groupings in cancer. Even if they're not in abnormal groupings, it will tell us which kind of cell has become cancerous. So for example, all B cells have the marker CD19 on them. All T cells or many T cells will have the marker CD2 on them. So we can start to work out what kind of leukemia this is and put it into a group of whether it's T cell or B cell. And then there are additional things that we do on top of that, looking for specific abnormalities that we can see in the leukemia. And these are molecular tests and cytogenetic tests that we do. And all of this builds us a picture of what kind of leukemia somebody has, what kind of treatment they might need, and also what their risk score is, which I'll explain a bit more as we go through. So one of the things that we want to look at when we find that a patient has acute leukemia is we want to understand what has happened to the chromosomes, so to the actual DNA, the coding in the cell that has maybe allowed that cell to become cancerous. So this is not the DNA that the patient carries in the rest of their body. This is not the DNA that's passed on to their children. This is just what is happening in the cancer cells themselves. And we know that there are some abnormalities in DNA that recur in cancer. So in leukemia in particular, we see many different abnormalities that are repeated in different patients. And some of those we know go with a good chance of cure. And those are primarily the abnormalities that we see in children. So over 50% of children will have what we call good risk cytogenetics, which is where they have a change in their chromosomes, which means that their chemotherapy has a very high chance of working. But we also know that there are some changes in chromosomes, which are what we call poor risk, which is where patients may need very specialized treatment. So something like the Philadelphia chromosome means that you need specialized treatment for your leukemia, or it may mean that you need a bone marrow transplant, because actually without a transplant, we know that chemotherapy on its own doesn't have a very high chance of curing that particular type of abnormality. So that again is information that comes through in the first couple of weeks after a diagnosis is made, which is really important for planning an individual's treatment. What about the age? I've just shown you that this is primarily a disease of children, but age, you can be of any age when you get diagnosed with leukemia. And what does that actually mean in terms of the treatment you can have and the chances you have of being cured? Well, I apologize for this. Is a really complicated slide, but this is just to show you the outcomes of adults. So this is over the age of 20, but primarily over the age of 25, treated on our last trial that was run in the UK, which is called UCAL14. And if you look at the y-axis, so the upright axis, and you can see it, you start with 100% of patients that are alive. And then over time, and time is along the x-axis, what you see is that there are less patients alive as years go by. And we've split it up by the age of the patient at the time that they were diagnosed. And what you can see is that the patients that are under 40, so that's the black line and the blue line, have the very best outcomes. And that with every decade beyond 40, the outcome for patients gets worse, and it's particularly poor for patients over the age of 60. So that's not that patients are not cured over the age of 60, but it's much harder to do that. So this is for patients that have all had exactly the same treatment. So it suggests that there is something about the age of the patient that also affects their chances of their leukemia coming under control and staying away. And we've been trying to ask ourselves, what is the reason for older patients not doing so well with treatment for this particular leukemia? And it's probably in reality a whole mixture of things. So we know that the abnormal cytogenetics that you see in older patients is different. And so probably the actual way that the leukemia itself behaves is different to the leukemia we see in children and teenagers. We also know that older patients often have other medical problems, so they themselves might not be able to tolerate the amount of treatment that a teenager could tolerate. But one of the other problems that has happened with this leukemia is that most clinical trials have not run over the age of 60 to 65. So until the last decade, we haven't had a lot of good information or clinical trial evidence of how best to treat people in an older age group. So we haven't even really been able to define perhaps what would be the best treatment for older patients. And this is something that really needs addressing in the future. So what's the aim of therapy for ALL? What is it that we're actually trying to do? And this might sound blindingly obvious, but it is actually quite important. So the first thing that we have to do is we have to get rid of the disease. We have to get patients into remission. And this is actually quite an easy thing to do in the sense that most treatments will do this. And then every other bit of treatment that patients have beyond the first month or so is all about stopping the disease coming back. And one of the things that has been realized for about the last two and a half decades is that achieving remission is not the same as getting rid of every last bit of disease. And if you don't get rid of every last bit of disease, then there is an increased risk that the disease will come back. And this has really brought about this concept of what we call minimal residual disease and how important it is to get rid of it. Otherwise, it will re-emerge and the leukemia will then come back. So what do we mean by minimal residual disease? Well, I find this picture very helpful. So if you think of cancer as an iceberg, every test has a limit at which point it can't detect the cancer anymore. So I think of that as the sea level of that test. So if you imagine this whole iceberg above the sea level and below the sea level is acute leukemia in a particular patient. And in this case, the sea level is what you can see by eye. So you can only actually see a very small amount of the total iceberg when you look down the microscope at the blood. And so one of the things that scientists and clinicians have been focusing on is trying to find tests that enable you to see the iceberg below the sea level, because what you need to do is get to that very bottom tip of that iceberg to make sure that you've got rid of every last bit of your cancer. And so this is more of a schematic of the same principle. And so what you can see is that first dotted line is what we can see by eye. So that's the sea level, if you like, for the iceberg of what you can see down the microscope. And when you get below that level, we call that a complete remission. So it's really important to get to a complete remission, but you could still have all of that disease below sea level still present. And so what we've had to do is develop tests that allow us to measure to much lower levels. And we're now able to measure very confidently down to that red line, which is what we call 10 to the minus 4. And actually some of our tests will allow us to measure down to the yellow line, which is 10 to the minus 5, which is a very, very few number of cells. But you can see that even below the yellow line, there is that possibility that you've still got some cells left, which could then come back up again over time, which eventually would lead to the leukemia coming back. And so understanding what is happening to somebody's minimal residual disease has probably become the most important thing now in how we risk assess a patient and how we modify their treatment. So all of that information that I've just told you, we then put that together into what we call a risk score, and we can really tell a patient what their risk is after they've had their first month of treatment. And we base that on the age of the patient, which currently we see it as an increased risk if a patient is over the age of 40 based on the data that I showed you before. We also look at how high the white cell count was at diagnosis, and we take a lot of notice about the cytogenetics and what they tell us about that individual patient's risk. But the most important risk factor above all of the others is what is the minimal residual disease state at the end of the first month. So how low below the C line have we managed to go with the first lot of treatment? And currently what we would say is that any patient who have a risk of any of those groups, including persistent minimal residual disease, we would recommend that they have a stem cell transplant if they're on an adult protocol. So what does that mean? How do we actually treat a patient? What does that look like? And I find it helpful to think of our treatments in terms of blocks of therapy. So to start off with, we give blocks of treatment that we call induction. And in the UK, we have what we call induction phase 1 and induction phase 2, or 1A and 1B. And at the end of induction, which takes us roughly a couple of months, we can give a very detailed risk score to that patient. We assess their minimal residual disease, and that's really our decision point. And that's the time point that we sit down with the patient and we really explain to them, this is what your leukemia was like at the beginning, this is how well it's responded to treatment, and this is which way I think that you actually need to go at this point. And that's really where we decide, can you carry on the bottom line there, which is more blocks of chemotherapy, or do you need to go straight into a stem cell transplant? Or do you need perhaps a mixture of both? Do you need a little bit more chemotherapy and then perhaps a reduced intensity transplant? And all of those options are possible, and all of those options are given with the aim of curing a patient. And those of you that have been through treatment, I'm sure will have had that kind of discussion at that point at the end of induction. So that's kind of really where we've been over the last 20 years. And what I want to just spend the last few minutes talking about is what have we got now that is coming? What is new for ALL, and how does that fit into everything that I've told you? And perhaps where is that taking us going forwards? So one of the really exciting things that has happened primarily for B-cell ALL is the advent of new immunotherapy drugs. And what immunotherapy essentially is going back to those markers that are on the cells, on the leukemia cells, the same markers that we were able to identify with flow cytometry at the point of diagnosis. So these are the markers that are called CD19 or CD20 or whatever. And so the markers are just normal proteins that sit on the surface of the cell. And what we're able to do is to develop these antibodies, what they're called monoclonal antibodies, which basically stick to those markers when they see them in the blood. And it's like putting a flag on top of those cells. So it's enabling your immune system to see those cells as abnormal, to see them as foreign, in a way that your immune system hasn't been able to do that before. And that's really the principle of immunotherapy. And immunotherapy has become a really common part of treatment for lots and lots of cancers, including lymphomas, melanomas, lots and lots of different cancers in the last 20 years. And more recently, we've now got evidence for its benefit in ALL. And I just want to tell you about the 3 main immunotherapy drugs that we now are using fairly routinely in patients with ALL. So the first one is a drug called Rituximab, and this is a monoclonal antibody that has been developed to stick onto cells that have got CD20 on their surface. And CD20 is a very common marker that is present on B cells. And we've been using Rituximab for treatment for patients with lymphoma, which is another cancer of B cells, for nearly 20 years now. But it's taken a long time to get the evidence to show that it's actually beneficial in patients with ALL. And the best study that has been done looking at Rituximab was done by the French study group. So this is called the GRAL study group. And what they did was they basically took their standard chemotherapy, and for half of the patients, they added Rituximab throughout all those blocks of treatment that I showed you in the schema just previously. And they actually added between 16 and 18 doses of Rituximab. And what they showed that if they did that, importantly, they didn't increase the side effects of the treatment, but they did reduce the chances of the leukemia coming back. So this is what's called event-free survival. So this is surviving without your leukemia coming back. And what they showed was that if you had rituximab, this is for B-cell ALL, then 55% of patients were alive without leukemia versus 43% of the same type of patients who had had exactly the same chemotherapy but didn't have rituximab. So that basically translated to patients surviving without their leukemia coming back in more cases. And as a consequence of that data, NHS England has very recently, I think just last month, now approved rituximab for use in all patients with B-cell ALL who are being treated with the aim of cure. So any patient now who is diagnosed with B-cell ALL should be offered rituximab as well as chemotherapy as part of their treatment. So that's a real advance for treatment of adult ALL. The second immunotherapy drug that we now have available to us is directed against CD19. So this is a marker that is on all B cells. And there's a drug called Blinotumumab, which is a really very exciting drug, which has been developed specifically with the aim of treating patients with leukemia. And I apologize, this is quite a busy slide, but what's really exciting about this drug is it's 2 monoclonal antibodies that have been joined together. So if you imagine that a monoclonal antibody is a Y-shaped molecule, they're basically joined together by their stem. So the prongs are basically sitting opposite each other like that. And what they do is one of the antibodies is directed against the tumor cells, so in this case, the leukemia cell, and the other antibody is directed against a healthy immune cell, in this case, a T cell. And the idea is that you're bringing directly your immune system, your healthy anti-cancer immune system, into direct contact with your cancer cell so that your own immune system can actually fight your cancer. And this was the first drug that was actually developed using this bispecific or BiTE technology, and others are now becoming available for other forms of cancer, but Blinotumumab was the first one. There is a downside to Blinotumumab in that it doesn't live for very long in the bloodstream at all. So when it's given, it has to be given continuously. And so patients have a pump like this, and the drug comes in a bag, and the drug is then running into a PICC line or a Hickman line through this pump, and it has to run continuously for 28 days, day and night. So patients have to take like a little rucksack home with them with the pump and the bag of drug in their rucksack, and they have to carry it wherever they go. And one of the problems is that anything happens with the pump, that you have to replace it or sort it out within 4 hours. Otherwise, the drug has to be thrown away and everything has to be restarted. So there are some problems with using it, but actually the drug itself is very neat. It's really exciting technology. It has no chemotherapy drug within it at all. It is purely re-educating the patient's immune system to see their cancer. And there's been some really exciting data in this use of this drug for 2 particular indications. Firstly, what it is able to do is it is able to change a patient who perhaps has responded to chemotherapy but still has detectable minimal residual disease. And by using Blinotumumab, you can get rid of that disease, the iceberg below sea level. So you can convert a remission that's still got detectable disease at a low level into a remission where there's no detectable disease left. And what we know is that if you're able to do that, the patient has a much better chance of survival. But this drug has also been shown to be very effective in treating patients with relapsed disease. And so I think without a doubt, we'll be seeing more Blinotumumab for use of patients with B-cell ALL in the very near future. And then the third drug that has recently been brought to market is this drug called Innertuzumab. And this is a drug, again, it's a monoclonal antibody, a bit like rituximab. So this is just a single one this time. It is directed against a molecular marker called CD22, which again is on B cells. But this time, rather than it just being a straightforward flag that you're putting on top of the cell, this drug's got a chemotherapy drug attached to it. And so as soon as it attaches to the cell, it injects that chemotherapy into the cell itself and then causes the cell to die. So you can see this little picture here of the Y-shaped antibody with the little I don't know what you call it really, like little sort of exploding particles on the side, and those are the chemotherapy drugs that actually enter the cell once the monoclonal antibody binds. And what's great about Innertuzumab is you can give it as an outpatient. This is a really straightforward infusion. You don't have to carry it at home in a bag. You don't need the pump. And it's been shown to be significantly more effective at treating patients with relapsed B-cell leukemia than standard chemotherapy. And as a consequence, this has been licensed now and approved for use in the treatment of patients with relapsed B-cell ALL. But what's also very interesting is that there's been some really good data come out of the United States showing that actually you can use Inoteuzumab as an upfront therapy for elderly patients with a little bit of gentle chemotherapy and get very good long-term outcomes, suggesting that perhaps this might be a very good drug to use as a first-line treatment, particularly for older patients. So what I hope I've shown you is that we are getting somewhere now towards personalizing therapy for patients with acute leukemia, where we're actually able to get a risk score and a specific set of information about an individual's leukemia that's allowing us to get some sense of what treatment might be best for them, so that we can actually personalize that going forwards. I'm not specifically going to talk about CAR T-cell therapy today, but CAR T-cell therapy is an absolute classic example of how you can personalize therapy for patients with relapsed acute leukemia. So this is just taking my schema again that I showed you at the beginning and just showing you perhaps how this might change going forwards. So what I see is that we might be giving induction treatment, but adding in novel agents to make it more effective and less toxic. And that might be particularly valuable for elderly patients who can't take the intensive treatment that we've traditionally used. We'll still be doing an assessment of an individual patient's risk, including all the things that I've told you already, but particularly focusing on minimal residual disease. But we may then be able to offer you not just either chemotherapy or transplantation, but actually novel agents going forward. They might lead into transplant or they might replace transplant. And what we hope is that we'll have more stories like the Rituximab story, which actually doesn't change the toxicity of treatment, but significantly improves the chance of survival and cure going forwards. And I think what we'll be doing is assessing patients' minimal residual disease throughout all stages of their treatment. So this is just what I think are our challenges going forward. We need to be able to prevent relapse. We need better predictors of relapse. We need good therapies for patients that have minimal residual disease that's still detectable. And we need to understand what novel therapies might do for us if we can use them as first-line treatment instead of using them at the point of relapse. We need to reduce side effects. Anybody who's been through treatment for ALL will know how bad the side effects can be. And we still don't have as many treatments for T-cell disease as we would like. And I think going forwards, trying to understand how our novel therapies, our CAR T therapy and stem cell transplant all fit in together is still going to be important. And we can't do any of this without clinical trials. So it's going to remain really important that in the UK, we have clinical trials available for patients of all age groups, not just children and young adults, but the older adults as well. And this is going to be a real focus for us in collaboration with our colleagues in Europe going forwards. And I just want to show you really, really quickly, this is just a very simple schematic of how many teenagers and young adults used to survive from leukemia before 2006. So this is taking 100 little figures on the left-hand side, and all the black ones are the ones that survived and all the red ones are the ones that died. And then we changed our clinical trials and we changed our treatments. And now you can see that this is the same 100 young people treated on a different protocol with a different set of treatment, and now all the little black figures are the ones that survive. So you can see that we are making advances and we are making real progress for patients going forwards. And I do think that the future is bright, and I'll stop there.
Thank you, Claire. That was a really great overview of the current landscape. Before I bring in our other panelists, I just want to clarify one thing, if possible. So we had a really interesting question asked right at the beginning as to whether an 18-year-old is classed as an adult. And I wondered if you could just explain a little bit more about where the boundaries between the different groups lie in ALL? Is it as simple as 18 is adult, or you've sort of hinted that there's a in-between group there in your last couple of slides? Could you just explain that for the audience?
So totally an 18-year-old is an adult, but what we know is that an 18-year-old is very likely to have pediatric type disease. And so, as I showed you with that incidence curve at the beginning, what you're seeing in late teens, early adults is probably the end of children's disease. And what we've shown, not just in the UK, but in many countries, is that actually treating young adults as if they had pediatric disease, so childhood disease, results in much better outcomes. And that little picture that I showed you of all those figures is very much related to that change in treatment. So an 18-year-old with Philadelphia negative B-cell or T-cell ALL, we would strongly recommend is treated as per a pediatric ALL. If, on the other hand, they had Philadelphia positive disease, we would strongly recommend that they were treated as per an adult protocol. So it's not a simple answer, but that's kind of where we are.
Great. Well, I hope that helps the person listening today. Thank you for that. I wanted to come to Tino next, if I may. Tino, could you just say a little bit about, very briefly, which treatments you remember having and how they had an effect on you, just to set the scene in contrast to the clinical discussion there?
Yeah, sure. In terms of myself, I actually got diagnosed in 2014 and underwent just chemotherapy and radiotherapy predominantly. And from the get-go, the side effects were, as Dr. Claire Rowntree pointed out, quite horrific at times, really. And also you have the challenges of the fact that it's not a short sort of period of time that you're undergoing chemotherapy for. It's quite long term. So in terms of, there's quite a lot of nausea, which is quite debilitating at times, and that was pretty much throughout the whole 3.5 years, really. And also, because of the steroids that were used, also end up with secondary diseases like AVN as well, which definitely affect you more long term when you're looking further past the actual disease itself. So it's definitely affects you in different ways, anyway.
Yeah, great. Thank you for setting the scene there. We'll come back to discussing the side effects a little bit more, I think, afterwards. That would be really helpful. Catherine, just to set the scene from a nurse perspective, I just wondered if you could, Claire's listed a number of different treatments, and you've also got the stages of various treatments. How do you explain all this as a nurse to a newly diagnosed patient? How do you prepare them for going into treatment?
Well, I think we break it down very simply to start with, because as you can imagine, when a patient's newly diagnosed, sorry about the mask, I'm in a shared office, there's an awful lot to take in. So basically, we give things to them in blocks and bits at a time as we go along through it, with just a brief sort of overview to start with. And it's not easy to give a completely clear plan from the beginning, because as Claire pointed out, actually that plan can go off in different directions depending on how they respond to treatment and lots of other reasons. So try not to make it too complicated to start with, and keep revisiting it, basically.
And does the care, I don't know if care you provide is the right way of saying it, but do you change how you approach that, maybe based on their age and the treatments that are available to them?
Oh yeah, definitely for the treatments that are available and the treatment regime that we're going to go on for patients. We'll break that down and individualise that for them, and I'll give patients individual schemes for them to follow and treatment plans for them to follow as we're going through it. Age, to some extent, obviously my younger patients will get different treatments. We're lucky enough in Nottingham to have a dedicated teenage and young adult centre. So my patients up to the age of 25 are treated there. So they also get extra support from extra charities and other things as well. So it's just good for them.
Great, thank you for that. We've had a few questions in, so I think we're probably best to start with some of those. Claire's a couple of questions about MRD and what this actually means. So somebody's asked what MRD means if it comes back indeterminate. I wondered if you are familiar with that term, and if so, could you explain what that means?
Yeah, so this is where this gets so hard for people, because as the level of MRD gets close to the C level for that test, if you like, so every test has got a limit beyond which it can't pick up anymore, but it's not a straightforward above it it's very clear, below it it's difficult. Around the limit of the test, sometimes the test just can't tell you the answer, and so you can get this result back where it says indeterminate, which is very disappointing for patients, because you really want to know, is it positive or negative, and sometimes you just can't tell. And so in the main, you have to just do that again. If it's indeterminate from the very beginning, then you just can't use it by that particular test. But usually we would try to do minimal residual disease using more than one test. So you would try and do it by flow cytometry and by a molecular result. So hopefully you can at least get a clear result with one or the other. But it is frustrating that sometimes you do get indeterminate, and it's just the difficulty of these tests being so sensitive.
Yeah. And Catherine, is there anything you wanted to add on that front? Is MRD quite a difficult concept for you to speak to patients about as well?
We talk about it in very similar sort of terms, and sometimes rather than the iceberg, we've used a bath, like a bathtub, as the same sort of principle, really, whereas you get water in the bath, and the MRD tells us we can look over the top of the bathtub and see how much is actually left in there. But it's a very difficult thing for patients sometimes to understand, but also it's very nerve-wracking. You know, waiting for these MRD results to come back is something that causes a lot of anxiety for the patients, and so it is disappointing when we can't tell them exactly, and obviously it's extremely worrying when it comes back as a positive result for them. So but it has revolutionized the way that we're able to plan treatment for patients. It's given us a much better idea of how well patients are going to do and plan their treatment accordingly. So they are very useful.
Absolutely. Tina, were you aware of what MRD was during treatment? Was it a concept that you discussed during your treatment pathway?
During my treatment, I actually had a couple of results that came back undetermined. So those were a period of time of just waiting, and obviously when you're waiting on something quite crucial like that and it comes back, that you just have to wait a little bit longer, then you that's all you have to do, really. But after the third test, that's when I sort of got a grasp of it and got a bit more of a better understanding of it. But even now, I'm still 100% not certain on it, but I think I've got the basic gist of it.
It is quite a challenging scientific concept to get your head around, definitely. Yeah. And another question, sort of a follow-up question to you, Claire. Someone's asked if there's like a certain period of time in which you can stay in MRD positive but not relapse. Is there like set time periods that these things happen over, or is it very much dependent on the person?
These are all very good, hard questions. It's very dependent, and it also is very dependent on, so minimal residual disease is there's the pace of it, which is I think what you're asking. The speed of change depends on the person. It depends on their leukemia, but it also depends on whether they're on their first treatment or whether their disease has relapsed. So the way that minimal residual disease behaves is often slower with the first treatment than it is at relapse. So if somebody has relapsed, then we still monitor minimal residual disease, but it can disappear and reappear very quickly. Whereas in the first treatment, often it can be very slow. But in reality, it is dependent on the individual. And one of the things we don't understand is what processes like CAR T cell therapy maybe does to minimal residual disease. So we're trying to understand that now. So it's minimal residual disease is a tool, really, that helps you describe where you are right now. It doesn't necessarily tell you what is going to happen to you in the future, but it might tell you that you need more or less treatment at this point in time.
Okay. I think that's a good way of thinking about it. Thank you for that. I guess the final question on MRD, actually, Claire, before we move on, is can MRD positive cause symptoms, or does that require a full relapse before you tend to notice the symptoms of ALL returning?
The point of it is, when you're MRD positive, you're still in remission by eye, so it would never cause symptoms. to be causing symptoms is when the leukemia is properly back.
I think that's clarified. Thank you. Where do we go next? There's quite a few questions come along. Just while we're on the topic of future treatments, somebody's asked, what about T-cell future treatments? And I think, Claire, you hinted at this at the end of your slides, that there perhaps is a gap here. Is there anything that's being currently explored for T-cell patients?
There is. So people are working very hard on CAR T-cells for T-cell disease, but you can guess by the name, the difficulty is that CAR T-cells are actually adapting and using T-cells to fight the leukemia, and it's much harder to get T-cells to fight a T-cell disease than it is to fight a B-cell disease. So I think that needs some really smart people working on it, and they are working on it, but we're a bit away from that yet. What we don't have is the same number of drugs coming to the market that we do for B-cell disease, and that is disappointing. What I would say though is that what our recent data shows is that people with T-cell disease do have a very good chance of cure with chemotherapy-based treatments. So actually the T-cell patients do well with treatment in the main. The difficulty is, what do you do if it comes back again? Because we don't have the same array of therapies at the moment, but we're hopeful for CAR Ts in the long term.
Is there anything you wanted to add about T-cell acute leukemia? Is it more difficult to have those conversations with the T-cell patients about limited therapy options, or does it differ? Does it change how you have that conversation with patients at the point of diagnosis about what the plan is at all?
No, because I think at the point of diagnosis, the outlook for people with T-cell leukemia is actually quite good.
Okay.
So we would be relatively positive and upbeat because the chemotherapy is successul in at least 2/3 of people. I think the difficulty is at relapse. And so at the point of conversation at relapse, you don't have as many options for patients. But at the first line, so at diagnosis, actually we'd be fairly optimistic for somebody with T-cell disease.
Yeah, Catherine, anything you wanted to add on the T-cell disease at all from your perspective?
No, I agree with what's been said, really. We just we give patients until there's reason for us to say, we're not going to cure them. The aim of our treatment is to cure you. So, we'll start off at that point, basically.
Absolutely.
So it's important to be positive and to remain positive without being unrealistic. So, yeah, that's how we would start the ball rolling as well.
That makes sense. Well, I guess this sort of follows on nicely, Catherine, that there are some patients for whom intensive treatment isn't appropriate. And I don't want to say all older patients, because that's absolutely not the case. But as you get older, you become more frail, which may mean intensive treatment isn't for you.
Yeah.
Could you just explain about what sort of things you would offer to someone who isn't eligible for intensive treatment?
Well, there's levels of being ineligible. So, it will depend on what is the problem. If they specifically got a heart problem and they can't have some of the chemotherapies, for example, which affect your heart, then we might have a reduced intensity sort of regime. Patients who are not eligible for anything at all, we might give them some very gentle, maybe oral chemotherapy, or just something to see if we can try and hold the disease. And actually, we have had quite a lot of success using things like Inoteuzumab in a context with more elderly people. So where they've tried or failed or not been able to tolerate something stronger, we've then put them on something like Innertuzumab, which has perhaps then gone on to be reasonably successful for a while. So there's lots of options from that point of view. It's not just a straight yes or no. Quite often, just because you're old doesn't mean to say we won't have things that we can offer you that can actually be quite useful.
Absolutely.
And we do tend to take that on quite an individual sort of basis, really.
That's good to hear.
Some people choose not to have any treatment, and obviously, again, that's their choice. And as long as they're aware of all the options, then we would also support you in that if that is absolutely what somebody wants to do.
Yeah, I think that's an important point to make. I think that's not something that's discussed very often in these kind of webinars. Of course, no treatment is an option, as long as you make that decision alongside appropriate advice, of course. I wonder if we could move on to side effects. Now, Tino mentioned a side effect of AVN, which I think we've worked out is avascular necrosis. And I wondered whether, Claire, you could just clarify what avascular necrosis is, and then Tino, I'll come back to you to learn a bit more about what that is.
So one of the problems, particularly with the pediatric style of treatment, is that there's a very large amount of steroids, particularly in the first 5 weeks. And for young people in particular, either whose bones are still growing or have not long finished growing, there is a particular risk of this thing called avascular necrosis, which is almost like a very early accelerated form of arthritis that tends to affect hips and shoulders, and it can be extremely painful, and it often causes quite rapid damage within the joint, and sometimes patients have to go on and have a hip replacement or a shoulder replacement, and that is really a direct consequence of primarily the steroid therapy, although it can also be related to the leukemia and other treatments as well itself. And it's not uncommon to see that, particularly in young men. And it's quite a debilitating side effect.
Are there, what are the most common side effects you tend to see other than that one in patients?
Well, Catherine probably want to add into this as well. So I mean, our biggest fear is infection. And we talk about that all the time with patients, and we tend to keep people in hospital actually for the first few weeks of treatment for ALL because the fear of infection is so great. But because ALL treatment uses many, many different forms of drugs, and there's hardly a week that goes by where you don't get a chemotherapy drug of some description throughout your whole treatment. And as Tino was saying, he was on treatment for over 3 years, and until the last bit of maintenance, he would have been having different drugs all the time. These are all toxic drugs, and it's very likely that you will have a nasty side effect to at least a couple of those drugs. And so it's very rare that people get away without having a serious side effect, as well as the more mild side effects, like, well, they might not be mild to patients, but the ones that are predictable, like hair loss, like change in taste, those kind of more predictable ones. There's also the unpredictable ones, which can be really quite nasty, because, as I say, of so many drugs that we use.
Thank you. Catherine, is there anything you want to add to that?
Well, no, just obviously agree. The side effect profile of the whole treatment regime as a whole is fairly huge. And as Tino sort of alluded to, I'll often say to patients, unfortunately, you are on the marathon of chemotherapy treatments, not a sprint, this one. And the side effects can be different as it goes along. We do what we can to sort of obviously counteract the side effects where we can, and give patients lots of information about it as we go along, and so they know what to expect and what they might encounter, and they understand that a little bit. And there are differences in things that affect patients that are worrying, like infection, and things that bother them, like hair loss. Just because it's not life-threatening, it can still be a big thing for you. So we do a lot of talking about all of that as we go along, and explain what you might expect and what you might get as we go through.
Are there particular side effects that you are able to control with drugs or things like that?
Oh yeah, I mean, I do think the antiemetics, that's the anti-sickness drugs that we've got now, are probably improved quite a lot. We're mindful of those as we go through the treatment, make sure people have got plenty of antiemetics. I think that as a rule, particularly in the first bit of induction, people don't always find the chemotherapy as bad as they thought they were going to. Chemo has a very bad media image, as I always say, where people are violently sick and terrible diarrhea and all that sort of thing. And quite often it probably shouldn't be like that. You can get phases where it is, but as long as patients talk to us, then we can help you with these things as far as possible.
I think there's a wider image of cancer problem there that some of these things can be controlled more than is suggested by the portrayals of cancer elsewhere. It's an interesting point. Tina, I wanted to come to you on the side effects thing. I mean, you've mentioned a few already. I wondered if you could just say a bit more about which side effects during treatment were most bothersome to you, maybe, or the ones that annoyed you the most.
Yeah, I think the lack of appetite and just general nausea is basically the first thing you notice. And even as a bloke, hair loss is a big thing as well because it affects your appearance, and especially at a younger age, definitely I think it plays a part in your confidence and how you're able to interact with other people because you're at an age where other people's opinions matter about stuff like that. So it definitely depends on what age you're getting diagnosed and treated at. And also, like the others have mentioned, there's all risk of infection because at one point I caught a bit of sepsis and actually ended up being in hospital for like best part of a month, really. So just being careful about where you go and how you interact with people and the things that you do consume and is definitely critical. And I'd say post-treatment, obviously, I would say the fatigue issue is obviously something that comes into play because you're in treatment for a long period of time and you're not just going to shake that off in a matter of weeks or years, really. So that's what kind of seems like the long battle going forward. But other than that, I mean, I've had a hip replacement myself, but then you just get to learn your own limitations, how far you can push that, really. But whereas in terms of the fatigue, that's a little bit more unpredictable because you could be a 10 out of 10 one day and then like the next morning wake up and you're absolutely knackered. So yeah, going forward, that's probably the main problem for me. But other than that, yeah.
I was going to ask you a bit about long-term impact, and there are a few people who feel that the side effects or the long-term effects of cancer treatment go on way past actually the end of treatment. I mean, you mentioned fatigue. Is there anything else long-term that has affected you?
Yeah, especially for myself and my other friends, because I was paired up with a few different people diagnosed with a similar type of illness. And apart from the physical side, it's also this fact that you're on treatment and you're almost on constant high alert for numerous amount of years, and it doesn't just kind of switch off when you come to that. So the mental health aspect is definitely something that needs to be addressed, because if you're suffering something like that for a long time, it definitely helps to kind of have an outlet and speak to someone after it. A lot of my friends tend, and myself as well included, tend to find that whilst you're undergoing treatment, you're almost focused on that, and then it's only after treatment's finished that's when you almost kind of realize what you've been through, and then that's when it starts affecting you a little bit more.
Absolutely, yeah. Catherine, is that what most patients at sort of past treatment talk to you about? Is it the mental impact rather than the physical impact of their illness that they're dealing with at that point?
Well, obviously it's both all the way through. We're treating a person, not a disease, is what, the way we like to look at it. But Tino's experience is really common, that when the treatment's at its sort of most intense physically, it's almost like people are coping and getting on with it. And it's only when the treatment eases off slightly or finishes that they seem to have then, if you like, the time to think, gosh, what's just happened to me? And quite a lot of people, if not, it's almost normal when you get to the end that people have a bit of a low mood and a bit of an episode where their mental health does suffer a little bit more. It's very, very common. And certainly we have as well as people like myself who do counselling, we've got a clinical psychologist, and an awful lot of her patients are actually post-treatment rather than during treatment, because I do think at that point is when it often has a psychological impact on patients.
Absolutely. Claire, anything you want to add about sort of the long-term impacts of treatment, physical or mental?
No, I think that's all, I just echo what's been said. I think that description that Tino gave so eloquently of that almost like a grief reaction that happens when chemo finishes is something we recognise. And I think one of the hard things with ALL, if you go through straightforward chemo, I don't mean straightforward as in it's straightforward, I mean as in you don't have a transplant, it's so long before you hit that. It's very different to patients, say, going through lymphoma treatment who will be finished in 6 months. So it actually feels very odd to patients to be having this kind of delayed grief reaction 2.5, 3 years later. And sometimes they can feel guilty for that because they feel like they should be grateful that they're alive and through it and in remission, but actually they don't feel grateful at all. They feel awful. And I totally agree with what Catherine says, that we perhaps didn't understand the value of psychology support until relatively recently, and it's something now that many centres are trying to put in place to help patients, because we recognise that if you don't fix the mental health bit, you can't get back to where you want to be, even if physically you're fixed, if you like. So as Catherine said, it's about the whole person and making sure that the mental health and the physical health is all dealt with so that you can actually heal and get your life back on track is just so important.
Absolutely. I think about it in terms of, we may one day find a cure for cancer, but unless we put all that support in place as well, actually we won't really have achieved that much, just fixing the physical side. Claire, I wondered if I could ask a little bit more about transplants and the role they play. So you, in your schematic, mentioned them sort of at that point of post-induction, you sort of make a decision around there about whether a transplant be used. Who sort of is in that bracket of maybe considered by a transplant? Could you just go over that again for us?
Yeah, absolutely. So transplantation is still the most powerful tool that we have against ALL, and we know that it works. And we know that both what we call the full intensity transplant, so that's patients that have some radiotherapy as part of the transplant, which is the traditional transplant, or what we now call reduced intensity transplants, which is the type of transplant we offer to older patients. We know that both of those types of transplants do work, but they both come with a big price tag, in this, not in terms of money, but in terms of side effects. And we know that any form of transplant can have side effects that are so severe that can actually be life-threatening side effects. And one of the really big differences between the adult approach to ALL traditionally and the children's approach to ALL is that the children's hardly ever need a transplant, and in adults we have done a lot of transplanting. So in that risk score I showed you at the beginning, anybody over the age of 40 in the UK is deemed high enough risk to need a transplant, and we would offer a transplant to everybody in that category. And I think that is something that we're trying to understand now. Do we need to offer as many transplants as we have done traditionally, or can some of the new things like Blinotumumab or CAR T-cell therapy, can that enable us to not do as many transplants as we used to do? And I think that the only way we'll answer that is with clinical trials. But I'm hopeful that we will do less, particularly the full intensity transplants, in the next 10 to 15 years. But we've got to be very careful that we don't throw the baby out with the bathwater on this one, because transplants do work and they are more successful first time around than they are if your disease comes back again. So trying to use them at the right place is important. And so that the reason that I spent a while talking about the risk assessment for an individual is to try and understand for each patient in front of you, what do they need to give them the best chance of cure, and how much side effects are we prepared to accept in order to get there, and trying to move away from cohorts, so just say like everybody in this bracket gets this treatment, but to try and say for this individual, what does this actually mean for them? And that's where we're trying to go with this. And I think a lot of our risk scores are going to get more sophisticated and more individualized, and we'll get better at it, but it's going to take time because it's a rare disease. And so to get that real understanding, you need to get the experience of every new therapy that comes along.
Absolutely. Catherine, is there anything you want to add on the role of stem cell transplants? When you're discussing them with patients, do they understand their role that they might play in their treatment pathway?
We try and help them understand. I mean, it can be quite difficult, and it's not always a clear yes, definitely transplant, no. You know, sometimes the patient does have a role in determining which way we might go down, you know, in terms of their treatment plan. But it can be a difficult choice. And when we're thinking about, we're mindful of survivorship. So we're mindful of side effects and treatment and getting back to your health, and what's the least treatment, if you like, that we can give you and yet still maintain your chances of long-term survival. And that's sort of what we're looking at. So we have that balance. We don't want to overtreat people and leave people with masses of side effects that they didn't need to have had, or go through a stem cell transplant which has increased risk that we didn't need to take. So it's this risk benefit balance all of the time that we're doing with these patients. And the more information that we're getting over time with things like MRD, that helps us to make those decisions more accurately. But there is still a long way to go for us to know for definite which is the best way to go always.
Definitely.
So helping patients understand that can be quite complicated. You know, we do sit with them and talk with them and explain that there are going to be different options and how we're making those decisions so that they're fully involved in it.
Absolutely. Yeah. And another question for you, Catherine, is what can people do to take care of themselves while they're having treatment in hospital? Is there anything they can do to sort of help themselves through a really intensive period, plus also there's the stress of being in hospital, which, to be honest, I don't think I've ever heard anyone say that they enjoy that experience.
And it's been extra awful, of course, during the whole of the COVID time, because patients haven't had visitors, which has just been so isolating for so many people. So that first induction bit where they're generally in hospital the whole time has been really, really difficult. So anything that we can think of to do to help with their mental health and their positivity and lessening the isolations helps. And so from a mental health point of view, it's worth concentrating on that even in the early days. But physically, keeping themselves safe in terms of infections, drinking plenty, you know, all of the usual sensible sorts of things, really. Reporting any side effects, because sometimes we'll get patients who've not mentioned something that can be relevant. So I always say no such thing as a daft question, just tell me anything that's going on and we'll tell, you know, decide if it's unimportant or not. So keep communicating with us, keep, you know, taking the medication as we've asked you to take it. Yeah, otherwise, no, there's not much you can do, really. Unfortunately.
Tina, I think maybe it's a good time for you to bring you in. Is there anything that any tips you might have for anybody listening who's about to go into hospital or is in hospital and needs to cope with that sort of intensive treatment? Is there anything you can recommend?
I'd probably say it's quite likely you're going to be in hospital for a long period of time. So just try and find something else to focus your mind on, and just if you're struggling with something, just find people to speak to, because that will just make the journey a whole lot easier than trying to carry it all by yourself, really.
What sort of support mechanisms did you use at that time? Did you like contact any charities or anything, or was it a bit too early for you at that point?
Yeah, I had quite a lot of help, really, in terms of like my family in general, and quite a lot of my friends came to visit me during that period. And also where I got treated, they have quite close ties with different charities. Unfortunately, at that point, I wasn't working for Leukemia Care, so I wasn't even aware of some of the help that was available. But in retrospect, it would have been quite nice to have some of that available for myself, really. So it's something I enjoyed very much. But recently, I did get quite a bit of help from Click Sergeant and other bits as well that quite based around the Christie where I got treated. So and it's always something worth bringing up to your consultant as well if you're struggling with anything regards to mental health or anything like that, and then they can sort of like point you in the right direction to get the appropriate help.
Some good tips there, thank you. Tabify, I muted myself. Apologies, everyone. I think we probably answered a lot of the questions we had, so we'll wrap up to sort of make our way towards the end now. A clarification point, Claire. Could you explain what a hyperdiploid karyotype is from your presentation?
Yes, so sorry. So the geneticists use lots of difficult long words, but basically hyperdiploid means that there's too many chromosomes. And actually, weirdly, you would imagine that would be bad. But if there genuinely are enough extra chromosomes to count as hyperdiploid, and there's a very specific criteria for that, then actually that's one of the good risk cytogenetic groups that we see. And it tends to mostly occur in children.
Great, thank you for that. I hope that's helpful for the person asking the question. The penultimate topic then, I think, should be looking out for signs of relapse. Maybe Tina, you're a good place to start with this. We often hear from patients that relapse is one of the most stressful things for them post-treatment to try and live with that fear day to day. Is that something that you relate to, and how do you cope with that?
Initially, during the first few months post-treatment, that was something that definitely played at the back of my mind. But as time progressed, it's definitely got a lot better. And I would definitely say it doesn't affect me on a day-to-day basis, but it does come into play probably a few days before I go for my bloods, like every 3 or 4 months. That's when I do have like a bit of a state of panic where like I probably won't sleep well the night before, and then the results always come back well anyway. So apart from that initial bit before your bloods, I think I'm doing quite well with it.
Great, that's good to hear. Catherine, is that something you hear a lot from your patients, that it's at that moment before they pop in to see you that they feel most worried?
Yeah, they can do, and I always make a point of trying to say that their bloods are all fine and normal as soon as possible into our consultation if I'm seeing them in clinic, just to reassure people. But I run a long-term follow-up clinic for my patients. And so we do tend to discuss sort of health anxiety, I suppose sometimes you could class it as, which can crop up, you know, later down the line. Some people get very hypervigilant about their own health, which in some ways is not an awful thing, because I do want patients to report anything that seems unusual. But at the same time, you know, if it's inducing anxiety and people are getting really obsessed, if you like, with relapse, then we can sort of try and address that for them. But yeah, and of course the side effects, there are long-term side effects which are different to sort of long-term side effects from treatment. You can get late effects as well, which is a different thing altogether. So we do tend to discuss that as well in the long-term follow-up clinics.
What sort of things do you tend to see as a late effect rather than a side effect that started during treatment and then continued?
Well, things that can start during treatment that carry on can be like continued fatigue. You can get peripheral neuropathy in the ends of your fingers and toes and things that can carry on quite long term. But we will also look out for late effects, things like the avascular necrosis, perhaps some, you know, heart problems or other problems like that you might find that just come on at a later date that might be as a result of your treatment.
Do you, in older patients in particular, find it difficult sometimes to take the treatment effects out of effects of sort of other things that may be going on if they have other conditions and things like that?
Well, it's just part of the general assessment of the patient overall. So you would take those things into account. If they've got past medical history which would be relevant or perhaps might impact on it, then obviously you would take that into account as you went along.
Great, thank you for clearing that up. Claire, could you just clarify how often you as a doctor tend to see patients post sort of maybe the end of the maintenance treatment, how often you see people and what the purpose of those meetings are?
So it's a very good question, and I've changed my opinion on this as years have gone by, and I think it really should be patient independent or patient dependent, because it's really important that people that have had a blood cancer that is curable understand that they get to a point where they're cured. And it's really important that we stop pretending that we're following them up for relapse where after we don't really think there's any chance of them relapsing, because as Tino described, that awful fear of coming to clinic and not sleeping for 3 days before you come, actually, you know, if we're not genuinely expecting that patient could relapse by that point, then we need to be really clear on that. And I think something, perhaps as Catherine describes, about moving from a doctor-led model to a survivorship long-term effects model, which is kind of saying, look, we're not thinking that your leukemia is coming back anymore, but we still recognize that you've had this really tough treatment and you're still carrying the scars of that, whatever that is, mental health, physical health. And this is how we want to empower you to own your health and move forwards and use the health services to your advantage when you need them, I think is really important. And I think sort of you know, I used to, when I first started treating people, I would have just kept on a doctor-led model of follow-up for a long time, maybe 10 years. But as lovely as it is to see your patients that are fit and well and cured, that's not the right thing for them necessarily. What they need to understand is that they've crossed that line of being a cancer sufferer and they've got over it and they've survived it. But actually now just making sure that they're empowered to access screening and healthy living help and all those other things that Catherine's so eloquently talked about is really, really important. So I think the amount of times that you see a patient and do their blood test is not important. What patients need to know is that they can get back and see somebody if they need you, but actually if they're well and life is good, they can move on. And I guess we all probably do that slightly differently, but it's really important that you don't think of yourself as somebody who's at risk of leukemia coming back forevermore, because this is an acute illness, and acute illnesses are not subtle and they don't hide for years and years and years and then come back. So, you know, everybody has a slightly different time frame before you can say that they're cured, but it's really important that you do name that.
That's a really lovely way of thinking about it. Tino, is that something that you relate to in terms of wanting to feel like you're moving on from this period of your life? So you're on mute.
Again, yeah, fortunately enough, I've now progressed from monthly checkups to then 3 monthly, and now it's once, I think it's once every 6 months now. So slowly but surely, I'm not having to go in as often, which is quite nice. But yeah, eventually, hopefully, I'll get to the point where it's once a year, maybe.
And you're looking forward to that point?
Yeah, but I do understand. Obviously, they have to take precautions, and it's for my well-being, really, isn't it? So, just have to roll with the punches.
Definitely. And so the final topic I wanted to cover today is sort of the future for this. And Claire, you touched on it slightly during your presentation, but I wanted to start with Tino and ask you what you think, what you'd like to see change about ALL treatment. Is there something you think needs to be done before I ask our clinicians?
I had T-cell lymphoma myself, so I would like to see more options there, but I understand it's a lengthy sort of process to sort of try and identify the best way of treating these sort of illnesses as well. Possibly a shorter course of treatment as well. That'd be quite nice. But if it makes you better, then it works. Then you can't really complain too much, can you?
I think it's important that we take into account what patients want when we do future research, as well as what needs to be done clinically. So you make a good point there. It must be challenging having a rare type or rarer type, and knowing the treatment options may be more limited because of that. Yeah. So then to Claire and Catherine, maybe Catherine first. What do you think the next big thing is for adult ALL? What would you like to see change soon?
Well, I think we're going along the right lines in terms of increasing our understanding of predicting perhaps which patients are or are not going to do well, and then finding new treatments accordingly. So, and that work's ongoing and improving all of the time. And that links into what we were talking about with survivorship, because as I said before, if we can tailor a treatment that's more individualized to you, that means we can reduce your particular side effects and the way you're going to be going forward into the future, assuming that, you know, we do cure you, which is always our aim. So I think that continuing to work on you know, different drugs that come through and how they affect the patients and how we can use them the most appropriately would be a good way forwards.
Great, thank you. Claire, anything you want to add? I know you covered a little bit of this in your talk, but anything extra you thought about during the course of the discussion?
I think what I said before, I mean, what we've talked about quite a lot is the toxicities of ALL treatment, and it is probably the most toxic leukemia or any chemotherapy regime, to be honest, pretty much apart from sarcoma regimes. It's probably the most toxic regime that exists. And so there's something about reducing the toxicity that we have to address. And we'll only be able to do that with new drugs and using those new drugs smartly in order to improve our cure rates and reduce our toxicity rates is where we're at. And I think there will be, I think we will see drugs like Blinotumumab being used much more early in treatment in the next 10 years than we've seen so far. And I think that will benefit those patients that are eligible for that. I think we may see Innertuzumab being used in the elderly, a bit as Catherine was talking about, but where we might actually be genuinely allowed to use it as the first treatment. And I think that again will really translate to some proper benefits. But the pace of this is hard to predict, because you need the trial data to allow the funders, so NHS England and people like NICE, to actually say that it's beneficial. And so you need the data, and this is a rare disease. So the pace is not as fast as those of us who are working in this field and people who are suffering from it would like.
Yeah, I think there's some good ambitions there. I'm going to ask a quick follow-up question. I know that was the last question, but CAR-T is something we get asked about all the time, which is currently only available in people up to the age of 25. Is there a realistic possibility that it will be available in a wider population of ALL patients in the future?
Yes, without a doubt. And there's, although, like I said, that, that ALL becomes a different disease in older adults, and there probably is a crossover around the mid-20s. There's nothing magical about being 25 versus 26. It's just that that's how the trials were done. So only patients up to their 26th birthday were included. And so that's where the licensing and where NICE have allowed us to use the drug, the product have come in. But it is effective. It's not the magic bullet. It's not a miracle cure, but it is effective, and it will be another really helpful tool for us. And I've absolutely no doubt that the age range will change in the pretty near future for B-cell ALL. We're a bit further off for T-cell disease, but hopefully that will also come.
Fingers crossed, that would be great. If anybody wants to know more about CAR-T, we've got plenty of resources on the website. I know we haven't explained in a lot of detail what it is, so please do get in touch if you want a bit more detail about what we mean when we're referring to CAR-T. Just while I wait for my final slides to come up, I just want to say thank you to the panel today for all your answers. It's been a really interesting discussion, and I hope everybody listening has found it useful. As someone's mentioned in the chat already, we will be making the video of this available for you to refresh yourself if you want to go back, or if you know anybody else who wasn't able to make it today, please feel free to share that. And yeah, make it as useful to as many people as possible. Okay, I think we're on the right slide now, thank you. So we just wanted to finish off by sharing a little bit about our services, just to make sure everybody is aware of what we offer. So plenty of information sources. We've got plenty of webinars coming up in the near future. You can find out more about those on our website by searching webinars. One particular information source I wanted to highlight is our podcast. Next slide, please. If you want to hear more about perspectives of patients, of how their journey's been, sometimes we speak on a specific topic, and sometimes we speak more generally about their whole experience from diagnosis to where they are now, but all share really, really interesting perspectives, and I hope you enjoy it. You can again find it by searching podcast on our website, or if you're familiar with podcasts, any podcast app should have it. If you're in need of further support, we've got a wide variety of ways you can get in touch via our helpline and WhatsApp service, still running our support groups virtually, hopefully in person in the fairly near future. And if you're in need of more technical advice, we've got our welfare and advocacy team as well. I particularly wanted to highlight the Counselling Fund. Next slide, please. So if anybody is struggling to get access to NHS funding or experiencing long delays in funding for counselling, we do offer up to 6 sessions funded for people affected by leukemia and related blood cancers. So please do get in touch for further information on that. And finally, here's our contact details if anybody wants to get in touch. final thank you to our panelists today. You've all been fantastic. Thank you for your time, and thank you everyone for attending today, and we'll see you again soon at the next webinar. Thank you all.